Okay, I think we'll go ahead and make a start of it. Just an initial reminder that this meeting is being recorded so that we can send it out to others who registered who may not be able to attend this morning. My name is Dr. Wayne Herman. I'm the Vice President and Chief Academic Officer here at Los Angeles Pacific University, and it's my pleasure to welcome you to this webinar, Unleashing the Future of Healthcare with AI. We're pleased to have Dr. Gloria Wu as the presenter this morning. Dr. Wu is an MD, a respected ophthalmologist and retina-vitreous surgeon dedicated to advancing patient care and medical innovation. She will tell us more about herself. I will not try to describe all of her achievements and accomplishments, other than to say we were very happy to congratulate her for having just completed LAPU's MBA degree. And so we're very pleased to have her as an alumni of LAPU and certainly many accomplishments in her own right before completing the MBA. So with that, I will turn it over to Dr. Wu to lead the presentation.
Oh, thank you. Thank you, everybody. And thank you for giving me this opportunity. I'm going to talk to you about healthcare and AI. And I want to thank all my LAPU MBA professors, Dean Lisa Phillips, Professor Franz Flores, who helped me with my capstone project, Professor Farmer, who was my first professor at the MBA program, and all my success coaches. And I love the discussions that we had online. So why do we care about healthcare as a sector? When we were little kids, our moms taught us to save the world and help mankind, and so does the Bible. In Genesis, the Lord God took the man and put him in the Garden of Eden to work it and take care of it. So that means not only people, but the environment and all of us. So the background, in 1956 to now, so in the summer of 1956, Dartmouth, there's a summer convocation, and John McCarthy coined the term. So that was the first time that was used. In 1960 to 1970s, we had the first AI programs, ELIZA, Shaky, natural language processing, and robotics. So Shaky the robot is in the San Jose Computer Museum, so you can actually visit it. In February 10th, 1996, I remember reading in the New York Times front page, Deep Blue, IBM beat the chess master, Kasparov, so a real human being. So that was a breakthrough, a big breakthrough, IBM. And then March 16, 2016, over the period of 4 days in Seoul, Korea, Google beat the grandmaster in Go. So Google pioneered the kind of neural nodes, thinking like the brain when we go from one part of the brain to another. So they pioneered that. And then the thing that everybody remembers, November 30th, 2022, after Thanksgiving, ChatGPT launched, and it changed the world, and it changed all of our thinking. So in 6 days, it had 1 million users. So obviously, Google took notice, Microsoft took notice, and Microsoft wanted to buy ChatGPT, which was from OpenAI San Francisco. Then January 2023, 100 million users in 5 weeks. So again, the stock price for Microsoft went up because they're thinking of buying it. So all these things are in the common parlance of everybody, your patients, your people, your best friend, your neighbor, your dog walker, your veterinarian, everybody, your doctor. So other LLMs, so to catch up, Gemini created Bard by March 2023, and it used Palm 2 DeepMind. DeepMind was the same thing that beat the Go Master in Seoul, Korea in 2016. It was a transformer module, and it used a neural architecture of nodes. So it aimed for reasoning problem solving with 166 languages. At that time, this is 2023, I think ChatGPT had less than 50 languages. So Claude AI came out, also San Francisco, a transformer model. So this uses constitutional AI, where once the human software programmers created the Constitution, it is totally run by computers. There's no more human input. So this is very cheap to run. And this is the latest thing. You should try it. It's very interesting. DeepSeek came out of Davos 2025, January, February. High Flyer China. It does reinforcement learning, reward engineering, emergent behavioral network, open source AI tools. It cost 1/13 the amount of ChatGPT. So it was way cheaper. And again, people were very interested. The day it was launched in Davos, Australia banned it because on the first page of DeepSeek, it says all your data will be captured in China. So obviously, this is not good for people who are concerned about government phones and everything. So recently, last week, President Trump banned it from all government mobile devices and computers. So this is something interesting for you to think about because there's also cybersecurity and political security. So when you query an AI chatbot, you're training it, you're providing free data, you're just giving it gobs and gobs of data. But anyway, it is useful. That's how Google has sucked us in. So Google has 8.5 billion searches per day, or 99,000 searches per second. So the time for you to just put down your pen, 99,000 people logged into Google. So think of how much money they're making. It's very interesting. So 4.5 to 7% of all searches are health related. And most of them are done by women because they're the sandwich generation, at least in America. So 70,000 searches per minute is healthcare. So by the time it takes you to walk to the kitchen to pour yourself a cup of coffee, 70,000 people have asked something about Google, about something about health. So this is how important health is to everybody in the world and to all of us. So obviously LLMs in healthcare, these AI chatbots are all called large language models or LLMs. So they do health education. It saves costs on nurses and staffing. For example, the nurse can pull up this answer and read it and edit it as it's being shown to the patient. So the nurse will prevent the hallucination that can occur. And it also helps with the problem with there's a nursing shortage. So if you go to the Bureau of Labor Statistics, you can see that nurses all over America, in every state, there's a shortage. So it increases health literacy for patients. So despite people who have lower socioeconomic classes and they're in rural areas, they all have a smartphone. So a great majority of them have a smartphone because some are very cheap now. And this allows them to ask about rare diseases and other things which they could not have asked because they were in an area of the country where there were no doctors. And by early January 2023, Mayo Clinic and Stanford called up ChatGPT and partnered with them so that their doctor emails could be rewritten by ChatGPT so we could all sound warm and fuzzy while we're rushing between room to patient. This is true. So insurance companies and Medicare use it to audit the charts to get back money from hospitals and MDs. So this is a very interesting phenomenon. So this is all done by the big data companies. So even though we call it ChatGPT AI, it's not only ChatGPT. There's the whole infrastructure of data. So if no data, no AI. So AI in healthcare is more than just ChatGPT. It's about data, velocity, volume, variety, veracity. So in this little chart diagram, you can see that there's medical claims, mobile data. So every time you go on your mobile phone, you look at your Apple Watch, somebody's collecting this data. There is also non-retail outlets such as CVS 1-Minute Clinic, hospital electronic health records, provider software such as in my office, I have eClinicalWorks, and opt-in genome registries such as 23andMe. There's patient registries, there is private payers and plan claims such as Blue Cross Blue Shield, United Healthcare, and government health plan claims and pharmacy claims. So all that is data about health. So all of you in the audience, you can all participate in this healthcare revolution. And maybe you are, once you even ask a query of Google, you already are participating. And even if you go in ChatGPT and ask it something, you're already training it. And by your secondary response, like the first response was not enough, and you ask it again, that second response, you've already trained it. And then if you come back an hour later, that response will be refined. So this is the velocity that's all these AI companies can do. And the volume, we're going to get to it later, and variety and veracity. So there are issues in healthcare. All of us at cocktail parties as doctors are always asked, well, why is it better in Europe? So let me give you a background. Healthcare spending in 2023 in the US is $4.9 trillion, 17.6% of the gross domestic product, and $14,000 per patient in the United States. That's a lot of money when you think about 380 million people. And so why is it that Europe spends less and there's everyone healthier? Well, number one, we have 380 million people. They don't have 380 million people. France may only have like 7 million, and Norway has like 5 million. So that's like the equivalent of the city of San Jose, 5 million. So you have to think about that. And we have gunshot wounds. They don't have gunshot wounds there, and gunshot wounds and knife stabbings, and they're much more peaceful, that country. So they have one electronic health record. So all data is available for everyone to see, like all of Spain can see the data. And the US has a fragmented system. We have Epic, which has 52% of the market in the hospital, Cerner with another 33%. And then the other 33% has like eClinicalWorth, free ones like Practice Fusion, Office Ally. So they're all competing because we're a capital system. So we have silos. So Epic is not going to give its information out to anybody else or any other electronic health record system unless they pay Epic. So there's no seamless integration of data, and the US government cannot see the trends easily. Sometimes they can see state by state, and so it is different from UK and Europe. So we need a unified healthcare system. When Obama got elected in 2010, he really envisioned this. But instead, we did not get to this till 2023 when Governor Newsom in California mandated healthcare data exchange. So, and how do we get better care? We need to get all of patient records when the patient shows up at the doctor's office. So if Mrs. Jones shows up at my office and she has cancer, I want to see her data when she went to Stanford, when she went to UCLA, and where she got all her cancer treatments, because it involves the eye and their eye side effects. So bidirectional data exchange means that there's a highway of open data sources. So interoperability means that all these little pieces of data are going back and forth. And that also means that you can query each piece of data and say, what day did Mrs. Jones have her first chemotherapy? Because Mrs. Jones is 80 years old and she may not remember. And what day did she have a response to her first chemotherapy that brought her a rash all over her body? So all these things are important. Then with this query, this ability to query the data, which is called interoperability, means that you can do care coordination. So now Mrs. Jones at age 80, we can figure out which best place to send her. Should we send her to MD Anderson? Should we send her to UCSF? Should we send her to Memorial Sloan Kettering for her third clinical trial? Because if you remember, President Carter, who was diagnosed with metastatic melanoma to his brain, they thought he was dying, and that was age 90. We gave him a chemotherapy, and then he lived another 10 years. So this was because he's number one, President Carter. He was near the NIH, and we were able to find out all the clinical trials that could help him. So now, fast forward to 2025, all the Mrs. Jones in the world could have this capability. So 47% of healthcare data is underutilized. Can you imagine? That's like a lot of data we're not using. So right now in different states, our EHR is siloed and segmented. So as I said, all these things, if they're siloed, they're barriers, they're firewalls. So the person in one computer, one doctor, cannot talk to the person in the other computer, another doctor, without calling, faxing. That takes time. What happens if Mrs. Jones is in the emergency room and she has a pacemaker, and her pacemaker is made by Johnson & Johnson, but we don't know that, And we need to know because they're like Medtronics, they're St. Jude's, they make all different pacemakers. So we need to know the code to unlock the pacemaker to make it behave so Mrs. Jones can survive her pacemaker problem, malfunction in the ER. So these are important things to think about. And how do we find and use this data? So we need government mandates and incentives. So what happens is, as I said, Governor Newsom in California gave the incentives. So California AB 133 passed 2021. It enacted in 2 steps. So January 1st, 2024, if you were a healthcare provider in a group of 25 or more, hospital, clinic, nursing home, hospice, you had to have this or start this process. He gave everybody $34,000 or up to $50,000. So that is an incentive. And then January 1st is the second part. When you're a solo doctor like me, we all have to have bidirectional data exchange. So this is happening in California, but it's not happening across all the states yet, but it is in the minds of the legislators. So there's a mandate and we need to think about it. However, now we have problems because people are worried with the Trump administration where they feel that this data can be taken by DOGE, Elon Musk and his group, and use that data and also to find all the people who are undocumented immigrants and not give them health care because that uses money from the federal treasury. So that's another political aspect of this part of data. So data exchange, you're going to hear these initials. I want to introduce them to you. And some of you may know this, and you can ask me questions later. So QHIO has the highest level of security, highest level of privacy for the patient. It's qualified health information organization, and it's certified to facilitate this electronic health information exchange according to the highest U.S. federal standards. This enables the QHIOs to serve underserved areas all over America. The next level, which is lower in terms of cybersecurity risk, is Health Information Exchange, HIE. They're at the state level. And FQHC is federally qualified health centers. And those are many of the health centers that provided the first COVID vaccines when they came out all over America. And they are at all the rural areas of our country and in California in medical deserts, such as Watsonville, Fresno, Modesto. So these serve a big population where there's maybe one doctor for 100,000 people. And so we have mobile health units that go to these areas, and they have the capability of sharing all the data. So with the rural and underserved, there's telehealth and remote patient monitoring. So RPM stands for remote patient monitoring. And what happens is the patient gets a blood pressure cuff connected to a computer, and they get monitoring real time at a local hospital or local groups. Telehealth is good, and sometimes it can be connected to your phone. And so again, we do need infrastructure, government backed for internet all over America. So that's another thing to think about. And health data and AI, what does that mean? So deep learning and medical record analysis. So as I told you about the IBM Deep Blue that beat Chessmaster Kasparov and Google DeepMind that beat the Go Master, that is deep learning. They used all the material and shoved it in their particular patentable architecture that is patent protected for Google, patent protected for IBM, patent protected for Facebook. They have trained them to use neural nodes. So it goes from point A to point B and then finally come out with an answer. Just like when we look at a red apple, we think about many things when we look at the red apple. So that's neural nodes. We think, number one, do we want to eat it? Number two, is it fresh? Number three, can I lift it in my hand? I touch it. Is it soft? Is it rotten? So those are neural nodes. So every time you go through Gemini. They use neural nodes versus ChatGPT, which is a different way of software programming. When you go through Gemini, it's going to go through neural nodes. So it's going to say, if I say, what's the weather today? And they know my IP address already. They already know that I'm here in Sacramento instead of my usual location in San Jose. So these are neural nodes. So they have sucked all this in by looking at your IP address. So think about it. In real-time analysis, we can look at 1.5 petabytes, 10 to the 15 pieces of data across 165 medical diagnoses. So the accuracy is 41.5% versus traditional methods without AI. So this is huge, this is fast, so we could think of everything possible about Mrs. Jones, who has cancer at age 80, breast cancer stage 1. So pattern recognition, this is important to think about. You know, when you were a little kid, they gave you IQ tests and they wanted to see if you could see these patterns. Well, as we grow up and we get older, we think about more patterns. And me in ophthalmology, retina, we're very visually oriented. We look at retina, we look at blood vessels, and for people in radiology, they look at pattern recognition for breast cancer, for is this normal dense breast tissue, or is this a lesion, or is this a cyst, or is it a cancer? So this is pattern recognition. So they speed it up for radiologists. Predictive analytics. So machine learning models forecast patient outcomes. If you're sitting in San Francisco and you're at San Francisco General and you have 65-year-old homeless population, but you have many of them coming to your emergency room, and you want to know, what are your resource allocation? Do they come to the emergency room in January or June? January, it's colder in California, in San Francisco than in June. So this gives you idea of how to do staffing, how many vaccine shots you should available, how many TB vaccinations you should available, and also about the amount of antibiotics you need. So natural language processing is the AI to extract meaningful information from unstructured clinical notes and medical literature, making this text-based data accessible for analysis. So that means that if IBM, which is doing it now, looking at the world's literature on cancer, stage 1, 80-year-olds, and they're going to find on the human genome, which they have, which is 3.2 billion base pairs, they're going to find out what little problem can we solve with a molecule, with a new monoclonal antibody that's going to fix that base pair problem. So that's going to improve drug manufacturing. Instead of taking 5 years to create a miracle drug and costing $1 billion, it's going to take 18 months, 6 to 18 months. So that is what IBM currently is doing. So clinical decision support, population health management, drug discovery and development. So for every chromosome, the human genome, which took us so long to get to, now we can go through all these base pairs in seconds. So this is amazing amount of data, how we can improve human life. However, the flip side, if you're an evil nation, you can find ways to kill off the world really quickly. So there is that problem. Operational efficiency. AI can optimize hospital workflows. Already there are smart hospitals like in Seoul, Korea, where they know if a patient has bed sores, the bed is timed to change the angle of the bed so the patient can be flipped without a nurse actually lifting the patient. So this really helps them flow. They also have ability in various hospitals in Korea, because they were the first to do this 15 years ago ahead of everybody else. They can monitor all the toxic molecules in all the airflow systems in their ORs. So they can know if there is COVID virus in the air. They can know if there is carbon monoxide in the air. They can shut down the OR. They can make it perfectly until, stable until they put the next patient in, because they want to make sure the airflow is good. So this is very important. And then personalized medicine. I told you that we could look at the human genome and change certain things. And this is a new field, and it is especially important in the field of cancer. Real-time monitoring. You'll see the photograph on this slide. That's a patient, that's the IV pole, there's a QR code. They're using a scanning device. So they're gonna know everything. They're gonna know, did the IV malfunction? Did the patient get the IV on time? And they can monitor, did everything that the nurses were supposed to do, was it done on time? Was it programmed on time? And then it can also monitor the real-time level of the antibiotic in the bloodstream. So all this, you have Scantron, like in the supermarket, they scan you. Well, now they can scan the hospital equipment. So smart hospitals and smart equipment is coming to America in the American hospitals. So here I was talking to you about medical imaging, and TensorFlow is patented by Google, PyTorch by Meta. They gave it open source to everybody. So it's machine learning applications for imaging. So here is on the right, there is, the right is actually the left-hand image for everybody, because that's how we view it in ophthalmology and radiology, just like shaking hands. So the right image is a normal breast, and here's the left with a lesion. So this TensorFlow and PyTorch has helped in diagnosing breast cancer, 99% accuracy for IBM. So IBM sold off this to GE, and this was part of Watson. So here, you can diagnose diabetes without a doctor. That's a retinal image. And again, this is using those two types of machine learning and image processing. And the bottom is looking at a breast lesion over time. So this is extremely helpful for everybody in medicine, for our family members who may have breast cancer, for our patients who might have diabetes, for our family members. And this one really changed the world. This article came out February 2018, Nature Biomedical Engineering, and it was popular. And it came from Poplin and co-workers at Stanford and Google. They took 284,000 patients, 300,000 retinal images. They bought the images from UK system where they was all loaded, because I told you the US system was siloed, and they used one particular instrument, which we all now have. I have it in my office. They took these images and they predicted cardiovascular risk factors, 97% accuracy. So that day was February 18th. I remember all my colleagues calling me, and my husband's a cardiologist. They were all calling each other, because this changed ophthalmology, cardiology forever. We knew it as ophthalmologists that we could look at your picture and predict this, but this showed us that we could do this without a doctor. And this showed us that we could really help people in the rural areas who have no doctors. This shows us that we can help people prevent stroke, heart attacks, if we can get even a picture of their eye. So this is very exciting and very interesting to all of us. So bioinformatics, as I said, this causes IBM to get newer molecules, and they're going to suggest these newer molecules to our big companies such as Pfizer, Novartis, all the big ones, and then create faster drugs to help treatment. And it theoretically should improve the FDA approval process. Of course, we're under a new administration where there are many budget cuts, and we hope that this is still working. They didn't fire all the workers yet, so we'll have to keep tuned. So with the genomic data integration of the 3.2 billion base pairs that we have accessible within minutes, there is, for cancer patients, there's 39.4% improvement in treatment response, because we can follow this faster, 44.5% decrease in adverse drug reactions. This is really important because there are many adverse drug reactions with the powerful chemotherapy drugs we have available. But think of President Carter. We saved him. He thought he was dying at age 90, and he lived another 10 years, and he was fabulous. He was speaking, he was teaching Bible study until a year ago, which was, he was 99 at that time. So for cancer patients, the treatment efficacy increases by 35.8%. So that means that cancer patients are living an improved life. So clinical informatics, so data integration and management. So this is something that all of you can participate in, even if you're not a doctor, even if you are not in healthcare administration, because we all may become a patient and we all have family members who become a patient. So number one, there's patient surveys. So there's a patient satisfaction score that all the hospitals administer. The reason they administer is because if they don't get a good report card, they are judged by the Joint Commission. The Joint Commission does the accreditation for hospitals. And if you have a bad score, Medicare won't reimburse the hospitals. The hospital loses money. So your patient satisfaction survey is important. So if you're in the hospital, if you hate that hospital, tell them why, because then they will improve it. Clinical outcomes, as we can see, if we have everybody's data, we can find out everybody who's age 80 or age 60, stratified by date of birth, and find out who does better with which antibiotic, which does better with Moderna vaccine versus Pfizer vaccine. And then there's safety events. So the safety events, such as what happens when people fall in the hospital, and how many people fall? Do they fall on day 1 of the hip surgery, day 3 of the hip surgery, because they're readmitted to the emergency room? And so we have to look at that. And what type of hip implant did they get? And how many nurses were staffing this patient? So these safety events matter. And then process compliance. Are the hospitals and are the doctors' offices complying with the federal mandates? For example, if you have diabetes, is your doctor checking your hemoglobin A1C every 6 months? Did he decrease it? Because everybody here knows, or may not know, that diabetes is a big problem in America, affects 27 million people. 87 million people have pre-diabetes and they don't know it. So we want to know, are we doing the right thing for our patients? And then number 6, staff efficacy and turnover. As I said, we need to know how many OR nurses do we need at midnight in Chicago, where there are a lot of gunshot wounds, versus Detroit, Michigan, versus downstate Brooklyn, where they just stab you. I know this because I trained in New York. And so staff efficiency, turnover, and how many nurses do we need to be in the 3rd floor? And what if your hospital is shaped in a big L? That nurse has to run around the big L from going patient room 1 to patient room 19. How many steps does that take? And how much does that delay patient getting care in room 19 versus patient in room 1, where the nurse's station is? And then hospital-acquired conditions, such as if you're going to the hospital and you get COVID-19, which you didn't have when you walked in. So what about that? And then resource utilization. What about those pages and pages of these hospital notes from a year ago? Did the hospital get paid? So that helps us. And the cost per patient. How can we cut costs? How can we increase costs? How can it increase the value of the care? So while Mrs. Jones is in the hospital bed, how can we make it good for her for that day? Should we have flowers? Should we give her chocolate insure? Should we give her ice cubes with her Diet Coke? How can we do that and make it pleasant so that she feels happy when she walks out of the hospital? And the discharge process. Is it fast to get out of the hospital, or you have to wait there and not get your car, picking you up and all this stuff? So we need to know that to make the patient experience good. So what I learned in business school, 6 Sigma, which is to define, measure, analyze, improve, and control. So these are all the things that we could do on the individual level as a doctor, on the hospital level, and also as a nation. How can we define, measure, analyze, improve, and control? And then, as we learned in Toyota, Kaizen, with each step of the way, can we make improvements? So these are questions that are very hard. And right now we have our federal government trying to do this, and we'll see what happens. It's too early to tell. And then the public health information and informatics. And how do we help communities stay healthier? There's CDC data, public health data. So we either focus on the population, individuals, or the community, such as TB or hepatitis. First of all, we don't want TB spreading because that would be bad. That would be a step backward. So we have to focus on the individual in the doctor's office who presents with this, the x-ray that shows a lesion, and then the positive blood result, because we don't want community spread. So the goal, what is our goal? Better health. We want to enhance it with public health. We can use it with e-health, with the mobile apps. First, the Apple Watch, a shout out to them for the Apple Heart Study 2016. They found 400,000 EKGs and they found 4% with atrial fibrillation. So a shout out to them because they didn't have to do it, but they went through FDA approval for the Apple Watch. And outbreak prediction and real-time management. So this is something important for all of us because we are part of the community. And then medical signal analytics, such as EKGs. This is a digital recording, and this can be now standardized and fed into a computer. And then brain scans for seizures after stroke, and for muscle after stroke. Is the muscle weak, and can we follow this? Blood pressure and sleep studies. So all this can be digitized and can follow not only an individual, Mrs. Jones, but for all the population of 80-year-olds who had a stroke or 60-year-olds with a stroke, we can stratify it and find out who does well, who does what, and who does better with whatever drugs. And health data and AI, there's standards, regulations, and barriers. And this is a vocabulary I wish you all know because it's important as we go forward so you can be analytical about what people are saying to you. So unstructured data is handwritten, faxes, PDFs. Structured is that we put it into a data warehouse, and in this data warehouse, we can query it. We can ask it questions. That's what we want. And so structured data already is computerized material like Google Docs, electronic health records, digital EKGs, and your sound for voice. So all those opera singers out there, we can trace you from age 20 to 40 and figure out when did your sound change and should we look at your vocal cords. And HL7 FHIR is fast healthcare interoperability resource. It's granular access to data, common language for healthcare data exchange, allows medical organizations to store, retrieve, update, and share patient data. So this is a standard that the QHIOs do and have, so that's important they have this. FHIR organizes the information in a hierarchical coding structure so we can query it. And then clinical document architecture is important because this gives you a header for metadata such as patient information, healthcare providers, document type. The body has sections that be coded by US standard vocabularies and contain CDA entries. So that means when I say stage 1 breast cancer for Mrs. Jones, and I'm in my little eClinical Works in my office, when it goes to Epic, it comes out as stage 1. It does not come out as stage 4. So this means this is veracity of data. This is the truth of the data. And this is what ChatGPT struggled with in the first month because it was hallucinating. The veracity was not there. The relationship to HL7, this is version 3. So it has to have this version. And the structured format, specific structure encoded for clinical documents. So this allows for easy parsing interpretation by different systems so that all our different coding structures, the way it is coded, can see it in one uniform way so that we can see the data when from my office to the next office. So the EKG does not get hallucinated. The EKG comes out clear and the same. So that's very important. Semantics, the standard vocabularies. So they're going to have the standard vocabulary so everyone's going to know, which is great because then we don't have to worry about what we saw in the first month of ChatGPT and the first month of the launch of Bard. They had to change Bard to Gemini because they were so embarrassed when it was launched in March 2023 that it said something bad about our telescopes in the sky, and everybody picked apart Google. So that was a bad day for Google. They lost 1/8 of their stock market share. So interoperability, that's the same thing as standardizing the structure and contents of clinical documents. That means this allows me to ask the data. I can ask it, does Mrs. Jones need XYZ chemo? Did she have it 10 years ago? So interoperability is such a fancy word. People throw it around, but it really means, can we query this data? So this is very important. So we have velocity, the speed of light almost, not quite, volume, gigabytes of data per second, veracity, that's the HLA 7 FHIR CDA, that's the fidelity of data. Variety, we can take all these CT scans, EKG tracings, all the imaging, the breast imaging, they can be seen from one place to another. So nobody should be able to make a mistake. So all mammogram centers are supposed to keep your mammograms for 7 years. So what does the future hold for us? The OR, there's already Augmetics. This is a company, MRI images in surgery using a VR headset. If I'm a spine surgeon, I use an Oculus goggle. I can see the MRI as I'm operating on the spine. I can turn it on and off. This is a fancier version of the Google Glass that came out 10 years ago. And then we have smart hospitals all over America, not only in Korea. And we can be connected to robots and computers in real time and kind of help people. For example, if there's a code, a cardiac arrest on the 4th floor, people would know immediately. Usually people still, they say code blue, everybody runs up there. But wouldn't it be wonderful if they say code blue and immediately a robot pops out of the ground and the things that you need, the IVs are ready, instead of somebody having to carry it from one hallway to another. So this is something we have to think about. The medical office, we now have ambient AI LLMs. Long Health, I work part-time for this company. M-modal dictation, Augmetics, which is an IPO. Augmetics is with an X that came out. You can now speak to it. For example, if I speak in Chinese, my patient speaks to me in English. The typing on the computer is in English. So this is outstanding. So I'm speaking in Korean, the person in front of me speaks in Arabic, the note is in English. So this is outstanding. This is a breakthrough. Part of it is with Amazon services, which provides the language services. Or you can go Google services, pay them. Google is more expensive than Amazon services, just to let you know if you want to start a company like this. And AI dictation is Freed AI. Long Health IO. Heidi AI comes out of New York. Freed AI, you can try it for free. It's $100 a month. It's for doctors. You can just talk and it just comes out. It's mostly in English, English to English. And then there's telemedicine. There's lots of them and we can all connect. So what else? Faster drugs. As I say, faster drugs. So instead of waiting 5 years and $5 billion, this is only going to take a few $1 million. And from bench to outcome would be 6 months to 1.5 years. So this would be terrific for all those cancer patients there with rare drugs that need help. So, and in summary, healthcare data is growing. As I told you, 47% of the data is thrown out. So you can go there and help everybody in healthcare. Healthcare data management has growth opportunities. It is $4.9 trillion market, and you are saving the world. First Peter says, each of you should use whatever gift you receive and serve others as faithful stewards of God's grace in its various forms. So all of you have gifts. So all of you can help us in healthcare. Believe we can change the world. So Mark 11:24. Therefore, I tell you, whatever you ask in prayer, believe you have received it, and it will be yours. Thank you. And if you want internships, if your student want internships, we have them at Long Health. Call me up. And it was a great time, my 2 years with LAPU. I loved every moment of my MBA. If any of you have any doubts, I did it, even though I got my MD years ago. And I did it on a full schedule, seeing patients, lasering patients, doing surgery, and I did it. So if I can do it, and I'm short, I'm only 5'1", so you can do it too. Thank you.
Dr. Wu, thank you very much. I did post a note to say people are welcome to post any questions you may have in the chat. I'll give a few minutes for people to do that while I share an anecdote that relates to what you shared. I have a very good friend who worked in IT for a company, a retail company that had pharmacies in their stores, be similar to a CVS or Walgreens here in America. This was in South Africa. And what he found as he analyzed their data was that they were asking pharmacists to come in and serve the customers, but they didn't know exactly when they most needed them. And so they would bring them in, and then they would often find themselves with not much to do because it was not a busy time in the pharmacy. And by looking at sales data that they'd collected over years, he was able to put together algorithms that said, well, for this store, this day, this time slot is when you are most likely going to need additional help in the pharmacy. And by doing that and working that out, he presented it to the directors of the company, and they were impressed with it. They implemented it, and I think they figured they saved $8 million, by adopting his way of saying, here's a predictive model that says when we're going to need the additional help in the pharmacy. So that's just one example of the kind of application of this, of what you're talking about. There is a question, are there any good textbooks or educational resources that you recommend on this topic?
This is such a new topic, AI. All the universities are doing online courses, and some are free. And there's Coursera, and you could look up things about AI in healthcare. Because of ChatGPT and the newness of this sector, and the fact that DeepSeek came this year in February 2025, it's really changing quickly. And I think that any of you want to teach a course, the world is open. Go create your own Coursera course and be enterprising. There's not a lot known about certain things. So I did publish 6 papers on AI in ophthalmology and AI in healthcare last year, and I have 2 more coming. So it's a big area. It's wide open. So as they say, one of the strategies for surviving is go where nobody else is. So this is one of them.
Yeah.
I do have one question, Dr. Wu. Thanks for that presentation. That was just incredible, highly informative. I gained so much from it. And of course, you're aware that we do have a degree in healthcare administration. So I have a couple of questions for you. One, obviously, there's so much opportunity in AI and healthcare. And for our student population, how would you prioritize the things that they need to be learning as they prepare to enter the workforce?
I think to be intellectually curious, be open, because sometimes you go into a class and you think, oh, this is going to be boring. They leave after 1 hour. But really give it a chance, because it's like 3 men and the elephant. Do you feel the tusk, the body, or the tail? Healthcare is multivariate, as I showed you in one of my earlier slides, that like 10 aspects to healthcare administration, healthcare AI. And it's a time to be creative. There are things that you never knew that there was a solution. But if you have a problem, it's a very interesting time, because many of these sources, for example, ChatGPT, Claude AI will let you do an API for free if you have a software program, and you can do fun things with it. And so this is an unprecedented opportunity. They're using it because they get free data, but you're using it because you can try out a free mobile app, and maybe you'll be the next millionaire coming out of LAPU and donate back to LAPU.
One of the things that you highlighted that I thought was really excellent was the different large language models and how they kind of process the data differently, or how they are more effective in one particular area than another. That might be some really nuanced understanding for a student to have who's not familiar with the differences between the different large language models. The other question I have for you is healthcare delivery. I mean, in terms of the future of healthcare and AI, how do you see that impacting healthcare delivery across the nation, across the globe?
I think it's going to make healthcare delivery cheaper. For example, if already we can train surgeons in Africa and Nigeria, we could be here in Boston or San Francisco, and we can be with them real time while they're doing cataract surgery. It used to be 5 years ago, there was a lag, but there's no more lag anymore. So we're doing it, and I think we can save more lives, make people's lives better, and we're looking forward to participating in that type of evolution and revolution. And about the ChatGPT models, they're very different. DeepSeek is best for things that already have guidelines, like the European Society of Cardiology and Stroke. They're really good at that. And they're really good at the American Heart Association guidelines for stroke. But if you want an essay about Shakespeare, you have to go through either ChatGPT or Claude AI, because they're trained differently. So Gemini now makes it a priority to put a reference where they got the data, so they prevent hallucination. They're trying to get people to see that they can look further, and they don't want to be sued for giving bad information.
Great, thank you so much.
There was a question about where people could find your research publications. I just found at ResearchGate, I did a quick query, and I'm going to put that into the chat here. But it sounds like, it looks like those are some of the, can ChatGPT educate multicultural patients? Is that one of your articles?
Yeah, and you could put me in Google Scholar, type in my name, and it'll come up. Yeah.
Okay. One further question here. Do you anticipate that healthcare accessibility will improve with AI utilization?
I think it's really important to know that right now, all our patients are on AI chatbot, because number one, it's free, right? They're sitting in their home, they have a red eye, or they have a headache. They either go to Google, which is a form of Gemini, or they go to ChatGPT, or they go to something, and they're going to say whatever, XYZ, and they have improved greatly from 2023. So they're about 90% accurate. The only thing they miss is the sense of urgency. Like, they're pretty clear about the facts, but the sense of urgency is missing. And it's very interesting, but they're getting better. So every year they're getting better, because every time you query it, you're adding stuff to it. And all my patients come, I'm seriously, 90% of my patients come with something that they found on Google. They printed out and says, I have this diagnosis. I said, oh, okay. Google wasn't my classmate in medical school, but let me try, because you want to be polite. You want to accept that they really want to know. But sometimes, they come thinking, I have a brain tumor, and all they need is, glasses or glaucoma eye drops. So some people think the worst things. So as doctors, all of us have to deal with this phenomenon.
Competition with Dr. Google, huh?
Yeah.
All right. Well, it looks like those are our questions for the day. Again, thank you so much, Dr. Wu. We appreciate you sharing your expertise in this area. And we will be sharing the recording of this with those who registered for the webinar. From LAPU, we want to wish you all a very good rest of the day.
And thank you to all my MBA professors, Dr. Franz Flores, Dr. Farmer. Thank you. Thank you for joining.